Hello, my name is Nicolas Giraldo, and I'm a chief resident in the Department of Pathology at Johns Hopkins School of Medicine.
And my name is Robert Anders. I'm a pathologist at Johns Hopkins School of Medicine, and I co-direct the Tumor Microenvironment Lab in the Bloomberg Kimmel Institute for Cancer Immune Therapy. We will review the following 4 ideas in this module: basic concepts of tumor immunology, talk about the current immune therapy biomarkers, how combination therapy is impacting this field, and then we'll talk about emerging biomarkers. So let's start with the tumor microenvironment and the anti-tumor immune cell response. The tumor microenvironment is made up of 3 components. First, the tumor cells. These are the cancer cells forming a mass. We believe alterations in normal cells, for instance, lung cells, lead to the development of cancer and a tumor mass. Second component are the support or stromal cells. This component allows cancer cells to obtain nutrients, such as through blood vessels, to allow the tumor to grow. The third component is the immune system. These are the white blood cells, many of which are capable of removing tumor cells. There's a delicate balance between these 3 systems, and these systems will determine ultimately if a tumor mass grows or is removed from the body. It was not clear until recently that each patient's immune system has the ability to destroy a cancer. The primary cells involved in tumor destruction are T lymphocytes, also called T cells. These cells play a relevant role in the eradication of infectious diseases, such as a viral infection. In this setting, in the setting of an infection, it takes about 10 days for the T cells to become activated, expand, and remove the infectious organism. In cancer, these cells require a series of signals to become activated against tumor cells. First, antigen presentation. This refers to the identification of the target that the immune system will lock onto to identify the cancer cells. Second, priming. This is where T cells receive additional signals that allows them to become activated and expand in number. Third, these newly primed and expanded T cells move into the tumor mass and destroy the cancer. This is termed immune-mediated tumor cell death. We now know from work done by Nobel Prize winners Professor Allison and Hanjo that cancer blocks the priming and immune cell-mediated tumor cell death pathways. They do this by exposing the T cells to immune blockers. The most well understood immune blockers are CTLA-4 and PD-1, which inhibit the T cell priming and immune-mediated tumor cell destruction steps, respectively. We can break the 3 steps of immune cell activation down in one simple diagram. On the left is a cell exposing the T cell to the immune target, also referred to as signal 1. Signal 2 further primes the T cells. After both signal 1 and 2, the T cell is ready to expand and make more tumor-killing immune cells. However, immune checkpoints, also called immune stop signals, are able to halt this process. The tumor cells use these stop signals to block the anti-tumor immune reaction. The tumor essentially hides from the immune system by using these naturally occurring stop signals. Essentially, The checkpoint inhibitors are a stop sign on the surface of the tumor cells that blocks the immune system from attacking the tumor. When a patient is treated with an immune-based anti-cancer therapy, they receive an antibody directed specifically at the checkpoint inhibitor protein. That antibody covers the checkpoint inhibitor stop signal. Once the inhibitor is blocked, the patient's immune system can attack the tumor mass.
Let's review some of the evidence suggesting that blocking these checkpoint inhibitors can cause or cure patients from cancer. In this study, more than 600 patients with advanced metastatic melanoma, a type of skin cancer, were treated with the tumor vaccine. This vaccine gave the patient's immune system a target on the cancer cells. On top of that, these patients were also treated with an agent that inhibit the immune blocker CTLA-4. By doing this, we could potentiate the immune priming given by the vaccine. The researchers found a 10% response rate and a significant survival benefit. This was an early indication that blocking or covering immune blockers would allow the patient's immune system to destroy cancer. Later on in this study, more than 200 patients with advanced lung and skin cancers were treated with agents to inhibit the immune blocker PD-1. The response rates were remarkable. Between 18 and 28% of patients demonstrated a response. Look at the examples here. Panel 1 shows a large tumor that is very small in panel 2 after treatment. Also, an extensive advanced pigmented skin cancer in panel 4, it's gone in panel 3 after treatment. Histologically, there was also regression of the tumor cells evident in panel 5 and less so in panel 7 and panel 8. This is another example of how removing or covering the immune blockers like CTLA-4 and PD-1 allows the patient's immune system to attack the cancer. The principle of blocking immune checkpoint inhibitors has revolutionized cancer treatment. The principle of immune-based anti-cancer therapy was so remarkable that those individuals responsible for its early development were awarded in 2018 the Nobel Prize in Medicine. The progress in anti-cancer therapy still continues. More and more immunotherapy anti-cancer treatments are FDA approved each year. Efforts are now focused upon selecting the patient most likely to respond to immunotherapy anti-cancer treatments. As investigators seek to define patients likely to respond to immunotherapy, it is clear that tumors which contain more immune cells are more likely to respond. Tumor-rich in immune cells, often referred as immune hot, show a 20 to 40% response rate, while those without immune cells, often referred as immune cold, are far less likely to respond. This is an important general principle in immune-based anti-cancer therapy in determining which patients are likely to respond to treatment.
In summary, tumor biology consists of an ecosystem made up of tumor, immune, and stromal cells. Checkpoint inhibitors are critical to T-cell activity and exploited by cancers to hide from the patient's immune system. Hot, inflamed, and cold, non-inflamed tumor environments are important concepts in designing immune-based anti-cancer therapy.
Patients-based indicators of response to a specific therapy are referred as predictive biomarkers. Let's look at the three most useful predictive markers in use today. The three of them would be PD-L1 expression by immunohistochemistry, mismatch repair deficiency, or also known as microsatelite instability high status, and then tumor mutation burden. The most widely used tissue biomarker in immuno-oncology is the expression of PD-L1 protein. PD-L1 and PD-1 are immune inhibitors that interact at the immune synapse. If a tumor sample expresses PD-L1, it likely indicates that the tumor is dampening the proliferation and function of T cells and thus is inhibiting the anti-tumor immune response. Patients treated with antibodies to PD-1 or PD-L1 can block the interaction, leading to immune stimulation and cancer destruction. It has been shown that up to 50% of patients with tumor expressing PD-L1 protein respond to this type of therapy. In contrast, only 15% of patients with tumors not expressing PD-L1 will respond. As I mentioned, PD-L1 expression is determined by immunohistochemical staining. Thus, the expression of PD-L1 on a tumor sample is a biomarker of response. It isn't a perfect predictor, but it enriches for patients most likely to respond to immunotherapy. The expression of PD-L1 is challenging to quantitate. There are many reasons for this, but that includes that many cell types may express this marker, most notably tumor and immune cells. Also, this protein can be expressed on the surface and or in the cytoplasm of these cells. Expression of the cell membrane seems to be the most significant, but this is not entirely certain. Finally, the number or percentage of cells expressing PD-L1 appears to be important in predicting response. It can be challenging to determine the total number of cells and the number of stained cells in a sample. At first, PD-L1 appeared to have a high negative predictive value, meaning very few, if any, patients without PD-L1 expression would respond to anti-PD-1 L1 treatments. As we mentioned before, now up to 15% of patients without PD-L1 expression may respond. The utility of PD-L1 expression on patient tumor samples as a predictive biomarker is unclear. While there's over 50 FDA-approved indications for immune checkpoint inhibitors, only less than 10 require a certain level of PD-L1 expression. Currently, the use of PD-L1 expression as a predictive biomarker is up to the patient's oncologist.
The central dogma of molecular biology is that DNA makes RNA and RNA makes proteins. To maintain this flow of information, our genetic DNA code must be replicated. Each time we make a copy, there is risk of an error, known as a mutation. Fortunately, most individuals have natural systems to correct DNA replication errors. The system finds mismatches in DNA base pairings and corrects them, similar to how a spell checker corrects our typographical errors. Some individuals are unable to correct DNA replication errors, and certain repetitive regions of the genome called microsatellites become unstable due to this phenomenon. Each DNA error that goes uncorrected can pass that error down the line and result in a mutant protein. These mutant proteins may be recognized by the immune system. If the mutant protein occurs in a tumor, this might be a target for the immune system to destroy a cancer. As you may guess, cancer patients with mismatch repair deficiency or microsatellite instability associated tumors are more likely to respond to immune therapy. Thus, mismatch repair deficiency and MSI or microsatellite instability are predictive biomarkers. Identification of patients unable to correct DNA replication errors can be done by three methods. First, PCR testing can measure changes in the length of microsatellites. This has been a standard test for 20 plus years. Second, immunohistochemical staining can look for the expression of the four mismatch repair proteins. loss of 2 of the 4 proteins is generally accepted as good evidence of mismatch repair deficiency. Third, next-generation sequencing can interrogate the mismatch repair genes. There are advantages and disadvantages of each technique. The first 2 methods are well established in many pathology labs. The third technique is not as widely available, but it holds promise of a more comprehensive evaluation of a patient tumor sample. The establishment of mismatch repair deficiency, or MSI high, as a predictive biomarker was shown recently in a 2017 study. In this study, 86 patients were enrolled during a 3-year period. 12 tumor types were enrolled. All of these patients had very advanced, unresectable tumors. To enroll, the patient's tumor had to be mismatch repair deficient or microsatellite unstable, also called MSI high. The results of this study were absolutely astounding. The objective response rate, meaning that a patient's tumor shrank in size, was 53%. The complete response rate, meaning that there was no evidence of residual cancer in the patient, was 21%. Based upon this study, the FDA-approved microsatellite instability or mismatch repair deficiency as a predictive biomarker for treatment with anti-PD-1 or PD-L1 therapy. Currently, screening of patients' cancers for mismatch repair deficiency or MSI high is being considered as a universal test in cancer patients. While the number of mismatch repair deficient tumor types responding to checkpoint inhibitor therapy is impressive, the response rate and duration are equally exciting. In this study, 233 patients with advanced mismatch repair deficient cancers were enrolled and treated with anti-PD-1 therapy. The objective response rate is 34%, and the median progression-free survival was 4 months. Some tumor types showed a nearly 50% response rate. This is critical data establishing mismatch repair deficiency or MSI testing as an important predictive biomarker.
The third predictive biomarker in immuno-oncology is the tumor mutation burden. These refer to the number of changes in the DNA sequence that we also call mutations that result in a significant altered protein product. The tumor mutation burden is determined by DNA sequencing of the coding exons of an entire genome. It is calculated as the number of changes or mutations per a given length of DNA. Generally speaking, greater than 10 mutations per megabase is considered a significantly elevated or high rate of mutation. There are currently 2 main methods to determine tumor mutation burden. First, whole exome sequencing. In this method, each and every exon in the genome is sequenced to look for changes. It is the gold standard, but it's expensive, and it requires a large patient sample for a large amount of DNA. The second method is targeted gene panels, where one sequences a portion of a genome and infers the rate for the entire genome. For example, if 1/10 of the genome was sequenced and 4 mutations were discovered, it is inferred that the entire genome would have 4 times 10 or 40 mutations. This second method is less expensive, less data intensive, and it uses less patient sample. However, today, it is unclear what is the minimum portion of the genome to sequence to get reliable data. In this study, the authors examined the tumor mutation burden at the objective response rate after checkpoint blockade. In the graph shown, the y-axis is the number of mutations per megabase, and the x-axis is the objective response rate to immune-based anti-cancer therapy. The size of each dot represents the number of patients in each study, and the text near each dot indicates which of the 27 tumor types were studied. As you can see, the authors found a good correlation between the tumor mutation burden and the response rate, such as that patients with more mutations had a higher response rate. It was not clear what level of tumor mutation burden was considered elevated enough to consider therapy. A panel of experts looking at multiple studies on about 1,700 cancer patients treated with different immune checkpoint inhibitors observed that a cutoff of about 10 mutations per megabase showed a good predictive performance across tumor types. For examples, we can see in the figure on the right that patients with melanoma and a tumor mutation burden higher than 10 showed a remarkably high response rate approaching 60%. Similarly, patients with small cell and non-small cell lung cancer and a tumor mutation burden higher than 10 showing a response rate of approximately 35%. In this study, tumor mutation burden as predictive biomarker was tested in 1,073 patients with 10 types of advanced cancer. The authors found an objective response rate of about 30% in those tumors with mutational burdens over 10, and only about 10% in those under 10. This data was sufficient for the FDA to approve tumor mutation burden as a predictive biomarker for anti-PD-1 therapy. This begs the question, is it possible to combine PD-L1 expression or mismatch repair deficiency, microsatellite instability status, and tumor mutation burden together to make an overall better predictive biomarker? Well, in the same study that we were mentioning before, the authors found that the objective response rate to be highest in patients' tumors with elevated tumor mutation burden and PD-L1 expression. This is shown in the first bar. This objective response rate was slightly lower in those patients with just elevated tumor mutation burden, here represented in the second bar, and even lower in patients with sample with just PD-L1 expression in the third bar. The lower response rate was harbored by patients that had both a low tumor mutation burden and no PD-L1 expression. In a different large genomic study including more than 50,000 specimens, it was found that most patients with high tumor mutation burden were also MSI high. This is represented in the figure on the right by the overlap between the blue and the dark gray circles. Nevertheless, as you can see in the figure, there is a small percentage of tumors that are MSI high, but whose TMB falls below 10, showing the intrinsic limitation of using 10 as a cutoff point. It is likely that in the near future, improvements in predictive biomarkers will develop as more individual biomarkers are combined rather than identifying one perfect marker for all tumor types. A study with more than 1,600 patients with different cancer types treated with immune checkpoint inhibitors showed it was the tumor mutation burden level within a given cancer type that better predicted survival rather than a given cut point for all tumor types. In other words, the 10 to 20% of gastric cancer with the highest tumor mutation burden respond better than the 80% with the lowest tumor mutation burden. This indicates, similar to PD-L1 expression, that the predictive nature of tumor mutation burden depends upon the tumor type more than the expression level or relationship to an universal cut point.
Let's look at an example patient that an oncologist might face. Here we have a 65-year-old woman diagnosed with stage 4 gastric adenocarcinoma. The tumor was biopsied and is shown on the left, and then that tumor sample underwent PD-L1 immunohistochemistry, which is shown on the right. We see that there's no expression of PD-L1 in this sample. Oncologist also requested staining for the mismatch repair proteins. And what we found is that all 4 mismatch repair proteins were intact. So this is a mismatch repair proficient patient. And then the oncologist also requested a tumor mutational burden determination, and that number was found to be 14 mutations per megabase. So let's look at some questions. First, do we need to confirm MSI status by PCR? No, not necessarily. It's generally accepted that either immunohistochemical staining for the mismatch repair proteins or the PCR NGS test for MSI is sufficient. Some practices may vary and request both. Can we use anti-PD-1 therapy despite this cancer lacking expression of PD-L1? Yes. PD-L1 expression is not necessarily required for treatment with anti-PD-1 or anti-PD-L1 therapy. Is this patient likely to respond to anti-PD-1 therapy? Yes. The patient's chances of response are not driven necessarily by the expression or lack of expression of PD-L1. It's driven by the fact that she has a very high tumor mutational burden. Recall that above 10 mutations per megabase is generally considered high. So to summarize the 3 biomarkers actively used in immune therapy, the number of cancer types responding to anti-PD-1 L1 that require quantification of PD-L1 by immunohistochemistry is holding steady. MSI and mismatch repair deficiency testing is useful in identifying patients likely to respond to anti-PD-1 L1 therapies. Pathology labs should anticipate more requests for MSI and mismatch repair status. Tumor mutational burden is an important predictive biomarker for anti-PD-1 L1 therapy. The optimal cutoff has been defined, but we anticipate additional tumor-specific tailoring. And multiple novel platforms without clear standardization of methodologies or cutoff points are currently limitations to this biomarker.
Let's now review the concept of combination therapies. Chemotherapy is rarely administered as a single agent. Rather, it is typically used in combination. So let's explore this idea in the setting of immunotherapy. The rationale for combination therapy is simple. Cancer often develop resistant mechanisms to single agents. It is a type of cellular natural selection. For example, therapy aimed to mutant KRAS will eliminate nearly all the mutant KRAS cancer cells. Only cells capable of finding a way to grow without mutant KRAS will survive and proliferate. In combination therapy, multiple pathways are targeted. CTLA blocks T-cell priming and PD-1 blocks immune cell-mediated tumor cell death. If both these inhibitors are blocked, then the two pathways are open for immune system to attack cancer. We know from preclinical models that dual blockade of checkpoints increases their efficacy. There are nearly 1,500 active combination trials with PD-1 and L1 blockade, and these combinations include other immune checkpoint inhibitors such as CTLA-4 and anti-LAG3 that we will be talking in a minute, but also combination with conventional cytotoxic chemotherapy, anti-angiogenic agents, and also radiation therapy. Let's take a brief look at some FDA-approved anti-PD-1 L1 combination therapies in the cancer type listed, namely non-small cell lung cancer, kidney cancer, and also hepatocellular carcinoma, or also known as liver cancer. Regarding the first, so non-small cell lung cancer, in this study, nearly 800 patients with advanced or recurrent lung cancer were enrolled and treated with chemotherapy or a combination of anti-CTLA-4 and anti-PD-1. The authors found a significantly better overall survival benefit in patients treated with both anti-CTLA-4 and anti-PD-1 as compared to the patients that received chemotherapy alone. When they stratified patients by greater or less than 1% PD-L1 expression in the tumor sample, they found similar long-term survival benefits in patients treated with anti-CTLA-4 and anti-PD-1, regardless of the PD-L1 expression level. This is shown in the figure on the right on the top survival curve in green in both the top and bottom panels. Patients with more PD-L1 expression seem to do slightly better, even in the chemotherapy alone group. This is shown in the bottom line in both panels, also colored in gray. Interestingly, the 2-year survival of patients treated with anti-PD-1 and anti-CTLA-4 combo was 5 to 10% higher than patients treated with anti-PD-1 monotherapy alone. Now let's have a look about renal cell carcinoma. In this study, more than 1,300 patients with advanced renal cell carcinoma were enrolled to compare anti-angiogenic drugs to both anti-PD-1 and anti-CTLA-4 combination therapy. The authors found a significant improvement in the objective response rate and overall survival, shown here in the survival plot on the right top curve in orange, in patients that receive combination immunotherapy. This was sufficient data for the FDA to approve combined anti-PD-L1 and CTLA-4 therapy for treatment of kidney cancer. Finally, in liver cancer, in this study that we're showing here, 148 patients from 10 different countries were examined for the treatment of advanced hepatocellular carcinoma. It is worth noting that hepatocellular carcinoma has been a particularly difficult cancer to provide any effective and tolerable treatment. There are some subtle variations in the doses, but essentially all patients receive both anti-PD-1 and anti-CTLA-4 combination therapy. They found that about a third of the patients had a complete or partial response. Another result showed that about 1/3 of the patients survived 24 months. This is truly remarkable and served as a sufficient evidence to lead the FDA to approve the combination immunotherapy for liver cancer.
So in summary, there's strong preclinical evidence suggesting that dual blockade of checkpoint inhibitors would result in a synergistic anti-tumor effect. Novel checkpoint inhibitor combinations have been approved by the FDA over the last 2 years, and it's unclear which combination therapies will best benefit each tumor type. Let's look at emerging immuno-oncology biomarkers. First, let's start with lymphocytes that reside within a tumor sample. As mentioned earlier, immune hot tumors are more likely to respond to immunotherapy. One simple way to separate these two tumor types is by the number of intratumoral T cells. The importance of intratumoral T cells was evident in a melanoma study from 2014, in which CD8 expressing T cells in a tumor sample were measured. It's the upper left panel. Patients with tumors that enlarged after checkpoint inhibitor therapy are shown on the right, with the word progression on the y-axis. Then tumors that decreased in size are shown on the left, labeled response. So what you can see is that a higher density of CD8 T cells, the top row, are present in patients that show response to checkpoint inhibitor therapy. The same is also true for the expression of PD-1 on cells within the tumor, and that's shown in the rightmost column. A similar result was shown in melanoma patients treated with anti-PD-1 and anti-CTLA-4. In this case, the T cells were quantified using mass cytometry. The leftmost panel shows more activated T cells expressing CD4 and CD8 in patients that respond to combination therapy, as indicated by the arrows. When separated into survival after treatment, shown in the center and right panel, it's clear patients show better progression-free survival following anti-PD-1 treatment if the tumor samples demonstrate high, upper curve, compared to low, lower curve, density of CD8 or CD4 T cells. A similar topic was addressed in a recent review article. Intratumoral T cells are a prognostic biomarker. Prognostic biomarkers predict patient outcome before systemic therapy. The most common example of a prognostic biomarker is TNM stage and grade of cancers. This system assesses the extent and spread of a cancer and is prognostic for patient outcomes. It turns out immune cell infiltrate is also a prognostic marker. When intratumoral T cell densities are determined with immunohistochemistry, there is a general trend toward longer survival in 25 cancer types. The strongest association is breast, head and neck, and colorectal cancer. In fact, for certain types of cancers, the T cell density is a stronger prognostic factor than standard TNM stage and grade. Methods for estimating immune cell infiltrate have been established for breast cancer, shown on the left, and melanoma, shown on the right. In breast cancer, the percentage of tumor area infiltrated by immune cells is estimated. For melanoma, the immune cell infiltrate is estimated into 3 indicated categories. Patients with breast cancers with greater than 30% of the tumor infiltrated by immune cells show better disease-free survival, top line left panel, in a study of over 2,000 participants. In a study of over 1,100 melanoma patients, those with the most brisk or dense immune cell infiltrates showed remarkable survival, top line in the right panel, while those without immune cells in the tumor showed poorer survival, bottom line right panel. Those with intermediate degrees of infiltration showed intermediate survival.
Now let's look at the lymphocyte activation gene 3, also referred to as LAG3. Similar to PD-1 and CTLA-4, LAG-3 function at the immune synapse. It is found on the surface of the lymphocytes and it binds a molecule called major histocompatibility complex 2 or galectin-3, which are expressed on the tumor cells. LAG-3 is a potent inhibitor of the T cell activation, thus it also decreases the immune reaction similar to CTLA-4 and PD-1. Early preclinical studies showed both PD-1 and LAG-3 are expressed on tumor lymphocytes. Since these two molecules work through different pathways, it is important to block both of them. That was shown in the study on the right panel. In these graphs, lines that curve up indicate a tumor that is increasing in size, while lines that are flat or curved towards the x-axis indicates a tumor is stable or disappearing. The top row shows untreated tumors increasing in size. The right column is fibrosarcoma and the right is breast cancer. The middle rows show tumor treated with either anti-LAG-3 or anti-PD-1. When treated alone, these tumors still increase in size. The last row shows that the dual treatment allows a few tumors to increase in size, but 7 to 8 out of the 10 samples show the tumors to disappear. This is preclinical evidence suggesting these pathways might both need to be blocked or to eliminate the tumor efficiently. Currently, more than 80 trials are investigating blocking LAG-3. Most of these trials are combination therapy with anti-PD-1 or PD-L1 or even chemotherapy. Up to date, 10 trials have posted results and we're showing some of them here. For example, one in breast cancer show a 47 objective response rate. Another in melanoma and one with multiple cancer types show an objective response rate of 16 to 20%. We anticipate more studies and data to develop in this particular area. Now let's review the MGMT biomarker. A protein called alkyl guanine DNA alkyl transferase, commonly referred to as MGMT, removes the alkyl groups from damaged DNA. This protects the genome and allows a cell to survive. Some chemotherapy damage DNA by alkylating a base, which can result in cell death. Some brain cancer lack this protein, making the cancer more sensitive to chemotherapy. Thus, MGA expression is actually a predictive biomarker of response to alkylating chemotherapy. MGA inactive tumor produce more DNA mutations. More mutations mean more tumor targets for the immune system. The question to ask now is, could combining alkylating chemotherapy in MGMT inactive tumors and immune-based anti-cancer therapy be more effective? There is data to suggest MGMT inactive brain tumors are more responsive to anti-PD-1 therapy. There are about 11 ongoing clinical trials in MGMT inactive brain and colon cancers.
So let's explore a future concept. Current concepts are detailed here under A. A is an immune hot tumor. This type of tumor is most likely to respond to checkpoint blockade. Dual checkpoint inhibitor therapy might give the patient the best chance of long-term survival. Under B is the immune hot tumor. However, the tumor is filled with immunosuppressive cells. Those immune suppressor cells are likely to express immune blockers, and the patient's best chance at survival is to remove that suppressive signal by adding a checkpoint inhibitor. Under C is the immune cold tumor. This tumor does not have many, if any, tumor immune infiltrating cells. efforts at developing vaccines to boost tumor immunity might be useful to bring immune cells into this type of tumor. So in summary, we've shown you that intratumoral T cell density shows remarkable prognostic and some predictive power. LAG-3 is a checkpoint inhibitor showing great therapeutic potential. And then MGMT is an example of combining DNA repair mechanisms with immune-based cancer therapy.